Hi everybody, welcome to the webinar. We're just going to get started now. So today we have Elaine Cooke to share with us. And so just before we start, I'm going to let you know that on the bottom right-hand corner we have the chat box for everybody. I don't regulate that, or I don't facilitate the conversation from there. But feel free to chat with one another. If you do have a question, you can type it into the bottom left-hand corner in the Q&A pod, and we will address those questions at the end. So without further ado, we'll get started. We are generously supported by Janssen and One Touch. And so I'm going to give it over to Elaine Cooke, who is a pharmacist and a CDE. She's a certified diabetes educator, and today she'll talk to us about diabetes medication. So Elaine, please take it away.
Hello, everyone. Just before I do it, I'm just going to mention to Sharon that someone can't see the visual, apparently, so in the chat box there. So today, yes, our topic is diabetes medications, and what we're going to do is just talk a little bit about, very little bit, of the difference between type 1 and type 2 diabetes, and what causes the high blood sugar when you have type 2 diabetes. And then we're going to go through the medications, talk about the oral medications, injectable, and insulin, and just a little bit about hypoglycemia. So I'm just looking at my little screen here. So as all of you probably know, if you have type 1 diabetes, the body has destroyed the cells that make you able to produce insulin, and that type 1 has to be treated with insulin. In type 2 diabetes, it can be either a lack of insulin or a lack of the action of insulin, and that's called insulin resistance. And of course, you all know, I hope, that type 2 diabetes is a progressive disease. By the time you get diagnosed with type 2 diabetes, the ability of your beta cells in your pancreas to produce insulin is already only at 50%. And that loss continues. So realistically, eventually, almost all people with type 2 diabetes will require insulin, even if it's just one shot a day to control their blood sugar. And there's a lot of fear about insulin, but I think you all just need to think of it as it's just another choice of therapy. So I have this little graphic, wait a minute, sorry, I forgot where I was. And you know, to treat your diabetes, you have to control your lifestyle. So you have to look at your portion control, the types of foods you're eating, looking at your weight, getting regular physical activity. And stress is very important, so you need to find ways to deal with stress as well. And of course, I'm a pharmacist, so when you're prescribed a medication, it's really important that you take it. And if you're not taking it, it's really important to let your doctor know that you're not taking it, so he doesn't think, well, they're on that and that's not working, so I'm going to try something different. So where does the high blood sugar of type 2 diabetes come from? A lot of times the very first thing that changes is that the liver starts to release more and more glucose, because glycogen, which is from where the glucose comes, is stored in the liver. And that increases your blood sugar, and primarily it's your fasting blood sugar, which is your morning blood sugar, that starts to increase at that time. And then the pancreas, it eventually will get so there's decreased amounts of insulin secreted, and when you have less insulin, the insulin takes the sugar out of your blood and puts it in your muscles. So if you have less insulin, more sugar stays in your blood, and again, it can increase your blood sugar. And there's another hormone that's released in your pancreas by different cells, and it's called glucagon. And glucagon actually lets your body release more sugar into your bloodstream. And even though you lose the insulin, you do not lose the glucagon. So the glucagon adds more and more sugar into your bloodstream. Then we have this insulin resistance. So the insulin would take sugar into your muscles and your fat cells for energy and for storage. But because the insulin can't work, it's like coming up against a brick wall, more sugar stays in the blood, increasing your blood sugar. The amount of carbohydrate you eat often increases because of this hormone, GLP-1, which is a naturally occurring hormone that all of us have, that helps regulate your appetite. It helps regulate the insulin secretion, and it helps regulate the amount of glucagon that's released as well. So all of those things combined, one or the other, or gradually maybe more than one of them, cause that increase in blood sugar. And the reason I've done this is because I wanted you to know, where do medications work? Often people tell me, oh, I have to take another medication, so I've been bad. No, it's physiological changes that I've just explained, and medications work in different areas. So sometimes you have to use multiple medications to get your blood sugar under control. So the drug called Metformin, and also insulin and the other two that are down there, they work by decreasing the amount of sugar that is, a lot of dietitians call it leaky liver, so the amount of sugar that's leaking out of your liver. And that's primarily where metformin works. And then we have, that causes lower blood sugar. And then we have medications that help your pancreas release more insulin. And those are the things that are glyburide, glycoside, glimepiride. And I'm going to talk about these in a little while as well. The repaglinide, the insulin, the GLP-1 drugs that are injectable, and the DPP-4 inhibitors. So don't worry about the names because they're going to come up in a little while. But what happens then is it increases the amount of insulin, and it suppresses the glucagon in different drugs, which we'll get into later. So that works to lower your blood sugar, right? And then we have drugs that are called thiazolidinediones, great big word, rosiglitazone, Avandia, pioglitazone, Actose. Their primary action is to decrease that insulin resistance and let the insulin take the sugar into your fat and muscle cells. Insulin does that as well, and metformin to a very small degree does that. And then we're going to have medications. Oh, by the way, it lowers your blood sugar. So then we have medications that work in the intestinal system, in your gut. So we have a carbose, which slows the absorption, and we have drugs that affect that hormone I talked about, the GLP-1, whether it be a GLP-1 added on or a DPP-4. And of course, what happens then is it's going to help to lower your blood sugar. So hopefully, that kind of overview just gives you an idea of why you need multiple types of medication. And please note that insulin tends to do all of those things. So, metformin. So metformin, its primary action is in the liver. As I said, it slows that release of the sugar from the liver. And secondary effect, to a minor degree, it decreases insulin resistance. And it's taken with food. Any of you that have already taken metformin know that it can cause some side effects. So if you take it with a small dose and gradually increase the dose, those side effects are diminished. And the maximum amount of that is 2550 milligrams per day, but about 1,500 milligrams, so 3 tablets a day of the standard tablet, is about 75% of the action of metformin. Those possible side effects, the nausea, the vomiting, the diarrhea, those are probably the ones that if you're going to experience, you're going to experience that one the most. Some people get headache, a little bit of agitation, sweating. Weight loss, some people think it's because it makes you nauseous, but there has been studies that show that it can cause a little bit of weight loss. And if you take more than 1,500 milligrams for more than 5 years, there has been some evidence that it might decrease vitamin B12 levels. But there's not enough information out there to tell you to supplement with B12. It won't hurt you, but you can do it. It does not cause hypoglycemia. This is a big misconception. I've had a lot of people tell me, oh, well, you know, I take an extra metformin if my blood sugar is really high. Well, it's not going to drop your blood sugar from where it is. It's going to prevent it from going higher by preventing that sugar coming in from the liver. So metformin by itself does not cause you to have low blood sugars, otherwise known as hypoglycemia, or a blood sugar of less than 4. What it does, and it takes about 2 weeks for it to work, is it has the biggest effect on what your morning blood sugar is. That's that fasting blood sugar. And it can decrease that from about 3.3 to 3.9 millimoles per liter, and usually it's not right away. It tends to take about 2 weeks for those effects to be noticed. And a lot of oral medications lower your A1C in this 1% range. So A1C, the test that you go for every 3 months, which is a percent number that reflects what your average blood sugar has been for the previous 3 months. In the case of metformin, it will lower your A1C approximately 1 to 1.5%. And then we have the thiazolidinediones. I'm going to call them TZDs. These are the drugs that have had a lot of study and bad press. And in Canada, you have to have a contract with your doctor to start this medication to know that you've been made aware of any possible side effects. And that's the rosiglitazone, known as Avandia, or the pioglitazone, known as Actos. What it does is it decreases that insulin resistance. So it lets insulin carry the sugar into the cells. And one of the things they noticed about this medication is that it tended to keep that effect for a longer time than a lot of oral drugs. And its secondary effect is it affects that sugar release from the liver as well. And again, by itself, it cannot make you have a low blood sugar because taking it does not drop your blood sugar down really quick. Doesn't matter if you take it with or without food. One of the challenges with this drug is it could take up to 12 weeks to work. And when it was a popular medication, a lot of people, and it was expensive and it still is, a lot of people think, well, I've taken this thing for 2 weeks and not much has changed. But unfortunately, it could take up to 3 months for it to have an effect. The side effects of those that I've listed there, probably the most important that came to light is the fluid retention. Fluid retention is retaining fluid in the body, which led to some heart failure, which is one of the reasons in the studies that were done that there was a slight increase in the risk of heart attack. But it was always not to be used in anybody who had heart failure. And now it should not be used in anyone that has any cardiovascular disease. Occasionally it could have caused an upper respiratory tract infection, so that would be like nasal stuffiness, etc. There have been some signs of it causing a wrist fracture. That's primarily been in women with long-term use. But as I said, this class of drugs nowadays are very rarely prescribed, although in the States they're starting to use them again. Again, its effect is primarily on that fasting, that morning blood sugar, and it decreased that by about 2.2 to 3.3 millimoles. And it's, again, affected A1C from about 1 to 1.5%, so very similar to a lot of these oral drugs. We have a class of drugs that they call sulfonylureas that affect the pancreas, the beta cells. So that's glyburide, glycoside, which some of you may know as diamicron, glimepiride, which isn't used a lot, known as Amaryl. And what they do is, I used to use an analogy like if your pancreas is a sponge, these drugs squeeze the sponge to get the insulin to release into your bloodstream so that it can work. And these medications, depending on the form, because some of them come as regular tablets and some of them come as long-acting tablets, like glycoside comes as a diamicron MR. Whereas glyburide is usually once to twice a day, diamicron regular tablets can be up to 3 times a day. And diamicron MR, even if you're taking 3 or 4 of them, only needs to be taken once a day. It's important when you're taking this medication that you have regular meals because this medication squeezes your pancreas to release that insulin. The side effects, hypoglycemia is quite common in these, especially if you've missed a meal or you've done more exercise. They do tend to cause a little bit of weight gain, up to about 5 pounds. If a person is allergic to sulfa, it's not always a problem, but it's a concern. Sometimes the doctor will give a trial of this to see. And the glyburide one should not be used in anyone who has kidney failure. The glycoside, which was the diamicron, that glimepiride, they're newer agents, and they are more dependent on what your blood sugar is, and I called it glucose dependent on these slides. So whereas glyburide, it's like the indiscriminate one of the bunch. It will squeeze your pancreas and release insulin no matter what. The glycoside and the glimepiride, they pay attention to what your blood sugar is, and they release insulin based on what your blood sugar is. So they're less likely to cause that hypoglycemia over the glyburide. And again, they decrease your fasting blood sugar, your morning blood sugar, almost up to 4 millimoles per liter, and decrease A1C 1 to 1.5%. There's another group that work very similar to those sulfonylureas, the meglitinides. They also work in the pancreas. So repaglinide, which is known as glucanorm, metiglinide, which is Starlix. These medications, they work really quick. So they have short-term, and it is, again, dependent on what your blood sugar is, release of insulin. And, of course, none of these are going to work, the sulfonylureas or this, if you don't have a functioning beta cell. People who've been on glyburide or this type of medication for a very long period of time and their blood sugar is going up, they probably don't have a lot of function left in their beta cells. This almost acts like an oral insulin, we'll call it, because it acts very rapidly. When you take this medication, you take it only with food, and it works very quickly, and it has its peak action within about an hour, lasts for up to 4. It's usually taken at the mealtime or up to 50 minutes before your mealtime, and they usually can take up to 1 to 4 tablets because it really depends on the size of the meal and how well it's working to control your blood sugar 2 hours later. This is a medication that's often used for people that are really irregular eaters. They don't eat at the same time of day. Whereas with the sulfonylureas, it's more important to have that regular eating. This one, because you don't take it if you don't eat, right? And it can cause hypoglycemia, but much less so than those sulfonylurea drugs, and it can cause weight gain. It reduces your after-meal blood sugar, so your 2-hour after meal blood sugar, by up to 3.3 millimoles per liter, which is pretty big. And it reduces the A1C 1% for the glucanorm or repaglinide, and only 0.5% for the metiglinide. And that's why we don't really see that Starlix product used very much at all in Canada. So then we have the Alpha-glucosidase inhibitor, and it's called Glucobay, or it used to be called Prandase. It's called acarbose. And what it does is it slows the rate of absorption. If you slow down how fast it makes your blood sugar rise, it's going to let the insulin that you do have work a little better. It's always taken with the first bite of the meal, and the dose should be increased slowly. So they take it with one meal, and then they could take it at other meals, or they might even increase the dose from 50 to 100 milligrams. And every 2 to 8 weeks is when they increase the dose. This drug has a really big problem with causing gas. It's all abdominal things. So, abdominal discomfort, the gas is something that's a real challenge for a lot of people. Someone told me you have to really want to be alone for this medication. And unfortunately, taking an antacid or taking some stomach medication does not relieve that abdominal discomfort. It by itself does not cause hypoglycemia. But should you be on this medication with any medication that can, it would be very important that you treated that hypoglycemia with dextrose tablets, not with orange juice, not with honey, because those are carbohydrates, right? And it would slow the rate of absorption. So if you had a low blood sugar when you're on this medication, you have to use dextrose tablets such as Dex 4, or there is a straight Dex tablet available. It reduces your after-meal blood sugar, almost 3 millimoles per liter, and it reduces your A1C from 0.5 to 1%. Then we had therapies that came out about 5 or 6 years ago that were called Incretin Therapies that have their action in the gut. And we have an incretin hormone that I was saying was naturally produced in your intestines, and it is released in response to eating. And the main one, there's a couple, but the main one is called GLP-1, or glucagon-like peptide 1. And there's lots of different actions of GLP-1 that helps your blood sugar be regulated. And when you have type 2 diabetes, you actually have less GLP-1 than someone who doesn't have it, and that's going to be important in a little while. And the challenge with the GLP-1 naturally occurring, it is inactivated within about 2 to 8 minutes in everyone by an enzyme that's called DPP-4, okay? And that happens in every person. So the multiple actions of GLP-1 naturally occurring to reduce your blood sugar, or in fact to maintain your blood glucose if you don't have diabetes, is again depending on what your blood sugar is, it helps release of insulin, helps stimulate that release of insulin. Depending on what your blood sugar is, it will suppress that glucagon. Glucagon would have come to your rescue, and if you don't eat at all day long, glucagon will produce sugar because your body needs sugar to act, right? But as I mentioned at the beginning, that glucagon in type 2 is often like on a rampage. So GLP-1 helps suppress that action of glucagon. It slows gastric emptying, so it slows the rate of absorption of food. And in animals, it has improved beta cell function and increased the beta cell mass. It helps give a person a feeling of fullness. It helps them realize when it's time to stop eating, which is when you lose some of your GLP-1, a lot of people with type 2 overeat because they don't have that action to make them realize that they're full. So, of the incretin therapies, DPP-4 inhibitors, they're around to slow the slow the inactivation of GLP-1, which I told you was inactivated by an enzyme called DPP-4. So these inhibit the action of that enzyme. So there's sitagliptin, which is Januvia, saxagliptin, which is Onglyza, linagliptin, which is Tradjenta. And these can be used by themselves, or they could be used along with metformin. And in fact, there's a combination of all of those medications with a different name, Janumet, Comboglize, and right this minute, the other one just left my brain, so I'll tell you that later. Side effects. Most people do not experience any side effects with this class of medications. It is possible it can cause that stuffy nose, but it doesn't have any effect on weight at all. And most people don't notice when they're taking it. It reduces the after-meal blood sugar, about 2.7 millimoles per liter, and its effect on A1C is almost up to that 1%, 0.8 to 1%. And then we have these are injectable therapies, GLP-1 analogues. So exenatide, which is known as Byetta, it's injected twice a day, 5 to 10 micrograms. It's given with meals. That's important. And then there's liraglutide, which is known as Victoza, which is injected once a day in the morning. This can be added on to metformin or onto someone who's taking metformin and a sulfonylurea as well. And I have seen a lot of people who are on it just by themselves now because it tends to be looking at multiple effects that happen in the body that cause the type 2 diabetes. The analogues are not broken down by the DPP-4 enzyme, so it's not affected by that. The side effects, nausea, more so with the Byetta. Up to about 36% of people get nauseous with Byetta. With the liraglutide, they start off being nauseous, but usually after about 2 to 3 weeks, that nausea diminishes. Anybody who's taking Byetta or the Victoza and still feeling nauseous should just eat smaller, more frequent meals. As well as the nausea, these medications can cause vomiting, diarrhea. It can cause hypoglycemia if it's used with a drug that does, like the sulfonylurea drugs. By itself, limited amount of hypoglycemia. Weight loss averages almost 2 kilograms, but there have been people that report significant amounts of weight loss and maintain weight loss with these medications. There have been stories of people losing 40 pounds or more. But the studies that were done originally with this drug before it was released, on average it was just that 1.9 kilogram, which is just under 5 pounds. It reduces your after-meal blood sugar by 2.7 to 4.5 millimoles per liter, so that's the biggest one that we've talked about so far. And A1C can be anywhere from 0.5% to 1.3%, and I have actually seen people that have had a 2% reduction in their A1C. So then we have a new class of drugs that has come out. Actually, it was released in Canada somewhere about February, and those drugs work on the kidney. So I thought you should know what happens normally in the kidney. So the kidneys play a really important job in maintaining your blood sugar control, because normally in the kidney, it filters about 180 grams of glucose every single day. But because it wants to keep that, it virtually reabsorbs all of that. So you get to keep that into your circulation because we need glucose for our energy, et cetera. It's our main fuel. So there are two sort of proteins that are in the kidneys, and they're called SGLT-2 and SGLT-1. The SGLT-2, it reabsorbs about 90% of glucose, and the other one about 10%, so that essentially no glucose gets excreted. Now, this is in someone without diabetes. When you have type 2 diabetes, number one, years ago we used to test for diabetes with urine tested because glucose was spilling over because it was exceeding the amount that the kidneys could work on. But in type 2, after a while, your body actually reabsorbs more and more glucose. So again, it adds to the blood sugar. So this SGLT2 stands for sodium glucose cotransporter 2, and it's the inhibitors. So inhibiting the action of that is going to let your body release more sugar because that SGLT2 helps reabsorb 90% of it, right? The one that we have in Canada is Canagliflozin, or Invocana. It's taken once a day before the first meal of the day. And what it does is it helps you pee out about 300 calories of glucose per day. It increases the urine, though. It can be used alone, or it could be used in combination with metformin. It could be used in combination with a sulfonylurea drug, and it can also be used in combination with insulin. It's not used in anybody whose renal function has decreased, and your doctor would know this number. So anyone who had an estimated GFR, or glomerular filtration rate, of less than 45, these people would not use this medication. So in the Canagliflozin, there's a number of side effects, and I don't know why that disappeared. Sorry. Of course, because you're helping pee out more sugar, you're going to pee more, increase urination. And it can also cause dehydration, which can cause that dizziness, that constipation, and the thirst. So with the dehydration, you're at higher risk of getting dehydrated if you're over 65, if you take blood pressure medications, and especially diuretic drugs like hydrochlorothiazide, or if you're on a low sodium diet, or again, if you have kidney problems, you're at greater risk of having that dehydration. It has been known to cause urinary tract infections because it's making a lot of sugar in the urine, as well as causing genital yeast infections. They have found, though, that they don't tend to be ongoing. Basically, you tend to get those infections at the start of the therapy, but after a while, it doesn't happen. Because it can keep more potassium in your body as well, there can be an increase in the blood potassium, so some of the kidney problems, this would be a big problem for them. There is an increase of low blood sugar if it's used with a drug that can cause low blood sugar. So if you're taking Invocana and glyburide or diamicron or glycoside or the Meglitinides or the insulin, there is an increased risk of this drug causing a low blood sugar, but by itself, it doesn't actually cause low blood sugars. It lowers the A1C up to 3%. This is a pretty large number and a pretty awesome result, and I think we're going to see a lot more people on this medication. And there are more of this medication coming, by the way. In the States, they already have a couple of different ones. So then I'm going to talk a little bit about insulin. So someone who does not have diabetes, then this light blue line represents the insulin that's released normally in a body. The B is breakfast, L is lunch, D is dinner, the HS is bedtime. So your body has a pretty rapid amount of insulin release to cover a meal when you eat, and then it tapers off and goes down. So you're looking for an insulin. If the insulin could mimic this normal insulin secretion, bolus means mealtime, then a bolus insulin that matched that would be a really good choice to look at. And our body has a requirement for what they call basal, or I'll call it background insulin, that you have to have a little bit of insulin all the time for your body's functions, for everything to work correctly. So again, if you could get an insulin that kind of mimics that basal amount that your body needs, then that would be an ideal insulin. So just as an example here, this is the normal, doesn't have diabetes. That was just like I showed you, and that keeps your blood sugar pretty much controlled. This is an American slide that I've borrowed, so that's why the numbers on the side are milligrams per deciliter and not millimoles per liter. Now, somebody who has type 2 diabetes, even if they're not on, this is just their naturally what happens in the course of developing type 2, is that you get a very blunted and delayed release of insulin. This is, again, why your blood sugar can be so much higher, because it's not controlling your blood sugar when your mealtime glucose level goes up. So, let's see. These are all the different types of insulin that are currently available in Canada. And you'll find many different charts, especially on the internet, that have slightly different numbers. These numbers, they come from the Canadian Diabetes Association's guidelines for the treatment and prevention of diabetes. So there's insulin that act really quickly. They're called rapid-acting insulin analogues, so they're man-made insulins. Humalog, which is Lispro, Novo Rapid, which is Aspart, Pedra, which is glutathione. And they really work within about 10 to 15 minutes, and their action 1 hour peak, usually 1 to 1.5 hours, and they'll have some residual effect for up to 3 to 5 hours. We have the short-acting insulin, which is known as regular or R or Toronto. This is a human insulin. In Canada, we have human, we don't have beef and pork anymore, which I'm sure you all know, but I've been around long enough that there was beef and pork insulin. It takes about 30 to 60 minutes for short-acting insulin to work. That's why it's really important, if you're taking anything that has an R, a regular insulin in it, that you take it at least 30 minutes before a meal. It can take 2 to 3 hours for its peak action to occur, and it can last up to 6.5 hours. Then there's an intermediate acting insulin, which is known as NPH or N insulin. It takes 1 to 3 hours to work, and in some people up to 4 hours. The peak action of that insulin is over 5 to 8, and then has an action lasting up to 18 hours. There are premixed human insulins, and these numbers represent how much R insulin and how much N insulin. So 30-70 insulin would have 30% of regular and 70% of N. And there's a 40-60 and a 50-50. They start to work because they're a premix. They're going to have the R action in that 30 to 45 minutes for the meal, and their peak action is 4 to almost 9 hours, and the duration is 10 to 16 hours. Again, this was if you're taking anything that has an R in it, and you were taking it for your meal time, you need to take it at least 30 minutes before a meal. We have biphasic insulin, which a lot of charts will call you a mixed analog insulin, but in fact it's not a mix of anything. It is just a portion of the rapid-acting insulin has had protamine added to it, so it has a longer action. So it has some immediate action and it has some longer action. And I'm going to show you some graphs of these in a little bit. So Humalog mixed 25, so 25% of it is going to work right away, 75% a little bit later. It also comes in a mix 50. That's usually for a bigger eater, so it has 50% of it working right away and 50% of it having a long action. Then we have long-acting insulin analogues. A lot of people are familiar with the name Lantus, which is glargine, which takes about 90 minutes to work, and it's basically a flat-line insulin. There is no peak. It's really the closest to mimic that basal insulin I showed you a minute ago. And its action lasts around 24 hours in most people. The other long-acting analog is Detamir, known as Levemir. It takes about 90 minutes to work. It does have a slight peak, doesn't go up really high, but it has a little slight peak. And its duration of action can be very dependent upon its dose and the person. So they say 16 to 24 hours. See a lot more people in this insulin on it twice a day. But both Lantus and glargine I have seen twice a day. So just as a graphic example of how fast they work, so So bolus or mealtime insulins, this would be the fast-acting, the rapid-acting, that Lispro, Aspart, Glucine, Humalog, Novorapid, and Apidra. This would be the R insulin. So just looking at the difference between these, the fact that the R insulin takes longer to work and stays around longer, it's not going to ideally control that post-meal blood sugar, and because of its action longer, it's probably going to cause more chance of a low blood sugar. Then we have the basal insulins, which is that background insulin. So we have the intermediate acting NPH. Again, its action is 12 to 20 hours. They may be slightly different numbers in the chart because, again, I've borrowed this slide from another presentation. The long-acting insulin analogues, such as the Detamir, in this case it's saying its action is 6 to 23 hours, again, dependent on dose. And it does have that slight little peak there. And then we have the Largine or Lantus insulin, and it, again, takes about 90 minutes to start working, but it's pretty much a flat line insulin. And again, probably mimics normal insulin secretion much better. So when you're using insulin in type 2 diabetes, when do they usually start it? As again, I said, it's just another choice of therapy. When a person is taking oral medication or other injectable medication, and their A1C is still elevated, they can't get it totally controlled, usually an insulin is added. And in type 2 diabetes, often just at bedtime to start with. So that basal or background insulin, once a day, could be most people bedtime, but it can be at NPH would be like twice a day, breakfast and supper. And I have seen both Lantus and Levemir or Largine and Detamir used in the morning instead of at night. Often that's so people will remember it more. So it's once a day. It's you don't stop taking your other medications. And quite often just that one insulin, so that's going to get your background amount of insulin done, looks after controlling your blood sugar for a very long time. And some people may never go past this insulin. The idea with this insulin is to start with a low dose, slowly titrate it up, so it's like 10 units at bedtime, and the person injects 1 extra unit every day until their morning blood sugar is less than 7, or whatever target your doctor decides on. So the long-acting, the Glargine, Detamir, they do mimic that natural insulin release much better and have a much lower risk of hypoglycemia, whereas NPH can cause hypoglycemia a lot more frequently. So this is just showing you the green line there is the NPH. When I drew this, I couldn't get too big of a peak, so it can cause low blood sugar between that, especially that 4 a.m. period of time there, if it's once a day at bedtime. And then the purple here, or the red, is the Lantus, the Glargine, so pretty flat. And then the Detamir has just that slight little peak to it. So just as a representation, that white line would be how your blood sugars would be going up. Okay? So often if you've been on that Lantus at bedtime and your morning blood sugar is great, but your A1C is still high, there's probably going to add a bolus or a mealtime insulin once a day, right? So usually it's a rapid acting because that's going to be mimicking the natural insulin better at breakfast, or they'll say you can pick the meal that has the highest change in blood sugar from before to after. But breakfast is quite frequently used because your body naturally has a bigger increase of blood sugar in the morning. And again, quite often, just those 2 times a day is enough to control a person's blood sugar for a very, very long time. So the rapid-acting insulin, it would be used 5 to 15 minutes before a meal. Humalog, Novorapid, Apidra, or Lispro, Aspart, and Glucine. And you would check your fasting blood sugar, and you would check your blood sugar 2 hours after a meal, aiming to get to that 8 to 10. Or your doctor might say, well, just check your fasting blood sugar before you take that insulin and before the next meal, and to see where it's at that time. This is just an example of a long-acting insulin, which would be, I've used the Glargine or the Detamir lines here, with just adding 1 meal. So the orange is representing the rapid-acting insulin. human insulin, which is the R and the N insulin. It does not mimic normal insulin physiology, so they have a much greater chance of the low blood sugar. Again, R regular Toronto, injected at least 30 minutes before a meal, or if you're taking a 30-70, 40-60, 50-50, again, you'll improve your blood sugar greatly if you're on that type of insulin and you take injected at least 30 minutes before a meal. NPH insulin is a cloudy insulin. It's very important. It's resuspended, never shaken before you use it, because NPH has a great variability from day to day. So just rock it and roll it back and forth 10 times each. Don't ever shake it. The premixes, such as the Humulin 30-70, the Novolin 30-70, that 30% R, the 70% N, those are probably the most common ones you see. This would be an example of using a combination, the 30-70 insulins. You can see that there's lots of spaces where there's blue underneath those lines, and those make you much greater chance of having low blood sugars and also not controlling the meal increase in blood sugar. So there's also an analog biphasic insulin, which again, closer to the normal insulin action, needs to be mixed by that rocking and rolling 10 times. And because it has analog insulin in it, it can just be injected 5 to 50 minutes before or even right after the meal. This would be an example of it. This one here is a Novo Mix 30, or like the Humalog Mix 25. And sometimes this is sufficient, although it looks like it's missing the lunchtime. Sometimes just taking a little bit at lunch, if that's a big problem, will be good for this insulin. So then basal bolus therapy. This is definitely done with analog insulin, the long-acting Lantus, Levemir, and the rapid-acting insulins. Because you've got the background with the long-acting, and then the rapid-acting is going to look after those meals. And that's what happens naturally. This isn't for everyone, but this is certainly what a type 2 patient is often doing. So this is just an example. Here's the background amount. And then we add in rapid for breakfast, rapid for lunch, and rapid for dinner. And you can see that's the closest to normal insulin release. So for insulin therapy, the side effects, low blood sugar is the premium reason that people have a scare about insulin, but it's something that can be managed. So low blood sugar is less than 4 millimoles per liter, and it's most often caused because people miss a meal or have more physical activity than planned or inject their insulin in a higher amount than they should. So preventing it is knowing those action times that I've talked about, following meal plans, always having extra carbohydrate around for physical activity, and always carry treatment for hypoglycemia with you at all times. And if you're going to do exercise, monitor before and during exercise or long driving. And weight gain prevention, it is a common side effect with insulin, but healthy meal plans and exercise and talking to a dietitian can really help you with that. So when you're using insulin, almost all insulins last for 28 days at room temperature. So when you're using it, you want to use it at room temperature. You do not want to put it back in the fridge. It doesn't extend its time, and cold insulin hurts. Levemir lasts 42 days. Anything that's cloudy, again, resuspend it by the rocking and rolling 10 times and never shake it. Always rotate your injection site. You want to pick an area about the size of a postcard, above the belly button to one side, onto the other side, below the belly button one side and the other, and rotate those sites weekly. So for 1 week, you use a postcard size area for every injection. Then you rotate so you're not using that site for 3 more weeks to help the skin heal. And always press on your tummy to see if you have any lumps or bumps, and avoid those because that could be something called lipohypertrophy. Always use a new needle. Dull needles hurt and can cause more damage to the skin, and lipohypertrophy is overgrowth of the fat in your subcutaneous tissue, and it changes the action of the insulin. You don't ever need to have a needle length longer than 6 millimeters. There's even syringes now that are 6 millimeters, and pen needles 6 millimeters or less. 4 is all you need. Stick it in straight in. Count 10 seconds before you remove the needle from the skin. And don't jab. Just put it there and put it in. So just to finish off quickly here, just a little bit about hypoglycemia. So mild to moderate hypoglycemia is defined as a blood sugar of 2.8 to 4 millimoles per liter. It causes like dizziness, confusion, sweating, weakness, hunger, trembling, drowsiness, and not everybody experiences the same side effects. If the blood sugar is less than 2.8, that's considered a very severe hypoglycemia and it needs a different treatment. So these are all the different symptoms that could happen in hypoglycemia, but the symptoms vary from every single person. Stop by your pharmacy and get a chart that gives you all of these. The trembling, palpitation, sweating, anxiety, hunger, nausea, some tingling, difficulty thinking or concentrating, some confusion, feeling weak or drowsy or blurry vision or having trouble speaking correctly or getting a headache. But everything varies. It's individualized. Dizziness. Always check your blood sugar. If you're having these symptoms, check to see if your blood sugar is less than 4 millimoles per liter. If you've had really high blood sugar for a long time and you're starting to get your blood sugar lower, you might experience some of these symptoms at higher than 4. You can treat it, but just don't over-treat it. Just take a little bit of treatment. So treatment of hypoglycemia, always test. As I already mentioned, some people get hypoglycemic symptoms higher when their blood sugar is starting to go down because their body's not used to that. So if it's 2.8 to 4 millimoles, you want to treat with 15 grams of a fast-acting carbohydrate, such as dextrose tablets. There's one called Dex4. When your blood sugar is less than 4, you take 4 Dex4, and they have 4 grams of dextrose each. You could take 3/4 of a cup of juice or regular pop, 2 to 3 teaspoons of sugar or honey, or have 6 lifesavers. Test your blood sugar 15 minutes later. Retreat if your blood sugar still stays less than 4. And if your next meal is more than 60 minutes away, you want to have 15 grams of carbohydrate and a protein, such as a half a cheese sandwich or a slice of whole grain bread with maybe a tablespoon of peanut butter. If the blood sugar is less than 2.8, you need more to treat it. You have to take 20 grams of a fast-acting carbohydrate, such as 5 Dex4, and 1 cup of pop, regular pop or juice, 4 teaspoons of sugar or honey, or 8 lifesavers. Again, always retest in 15 minutes to see if your blood sugars come up, and if necessary, retreat it. And if your meal is more than an hour away, have 15 grams of carbohydrate and a protein. If the person is unconscious, and you would know if you're on insulin, it only usually occurs in type 1 individuals, they would administer another injectable therapy called glucagon. And that is that. And if you have any questions, I'd be happy to answer them.
Thank you so much, Elaine. That was really, really clear. So thank you, everybody, for coming. If you have questions, please enter it into the Q&A box on your bottom left-hand corner, and I will facilitate it and ask it to Elaine. As you are thinking about questions, if you have 2 minutes, just fill out the post survey. You can just click on the link right there, and again, it will help us just to better our programs. And I guess just as people are thinking about their questions, I have one question. So, Elaine, if somebody was to take home a message today, what would that be?
I think it's really important to know what the medications are that you're taking, how they work, and I think you need to know what your doctor has decided or your endocrinologist has decided is your target blood sugar. In general, people are to aim for 4 to 7 before a meal and 5 to 10 2 hours after, but those could be individualized. Testing with the blood glucose test strips is really important for someone who's on a medication that might cause a low blood sugar or might cause, basically it can cause a low blood sugar. People who just take metformin or that, you don't have to test a lot because it doesn't tell you anything. I always tell people if you're going to test with a purpose. Test with some idea in mind. But it is important if you have a medication to understand it and to take it.
Thank you. So just a couple of comments. People are really enjoying the presentation, and they just want to thank you for the presentation. So I do have a question here. Should someone seek advice from an endocrinologist before going to insulin? I'm type 2 and have been on metformin for 12 years.
Usually your family physician can start you on it. It's not necessary to go to an endocrinologist. And in fact, if your doctor is familiar with insulin therapy, or he might send you to a diabetes education center or to a CDE pharmacist like myself to help you start it. They have found, especially in type 2 diabetes, using that long-acting insulin analog like Lantus or Levemir, very safe and very easy for a patient to self-titrate. It is not necessary to go to an endocrinologist. If you've been on metformin by itself, often they'll try using some kind of a sulfonylurea first if you're only on metformin.
Thank you. Another question here. What are the possible side effects of, and I'm going to butcher it, Canagliflozin?
Someone told me we have to think about that Canada is frozen, so Canagliflozin. Anyway, the potential side effects are, again, excess urinary excretion. The dehydration is the big concern with that medication. There also the urinary tract and the genital yeast infections. Those are probably the most common side effects with that medication.
Thank you. Thanks for teaching me how to pronounce that. Another question here. Is it okay to take metformin if your kidney function is low? I am also on bolus and basal insulin.
Usually with metformin, they usually discontinue that medication if you're in renal failure, and they may choose to make that in what they call eGFR of less than 30, or renal failure is actually less than 15. I have seen them take people off of metformin when it gets to that kidney level. It really depends on what that kidney function really is. And also, what was the rest of that question? Sorry, you're on basal and bolus. The reason they use metformin along with insulin is they believe it helps keep the dose of insulin to be a little bit less.
Perfect, thank you. Another question here. My aunt has diabetes type 2 in her old age, passed away at 97 years old, but never needed to take insulin. This relates to your saying that everyone having type 2 diabetes will eventually have to take insulin.
There are lots of people that probably can manage it with diet and exercise, but it's rare. I think if you look at it from I'm trying to remember my statistics. They say, I said everybody, but they say approximately 60% of people with type 2 diabetes will require insulin. Those that, if someone who gets diabetes and it's just almost like a pre-diabetes and they're just taking metformin, they may never progress past having diabetes. It's all dependent on what your blood sugar is. But I said that because I want everyone to realize that it could be an eventuality in them, because a lot of people think, oh no, it's the worst thing ever that could happen. But I always look at it, if someone has low estrogen, we give them estrogen. If somebody has low testosterone, we give them testosterone. If somebody has low thyroid, we give them the thyroid. But if somebody has low insulin, it seems to be the last thing we think about. And I think people are put off of it too long. You would feel so much better. It's only what's necessary. If you can control it the other way, fine. But if you can't, I just want you to take away the idea that insulin is a punishment. Insulin is an excellent treatment.
Thanks for that insight. So just a reminder for our participants, if you like to ask Elaine a question, it's easier for me just to keep track of the questions if you entered it into the Q&A pod on your bottom left-hand corner. So the next question is, are there charts to guide us on how much insulin to take for corrective action?
There is a formula that your diabetes educator can calculate for that. If what you're talking about is if I'm already on insulin, but my blood sugar is high, how much do I take to bring it down? There is a formula based on what your total daily dose is. I don't want to say what it is because I don't want you guys playing with it by yourselves, but you always have to look at it this way. You can titrate it based on what your blood sugar is, either for a basal insulin, what your fasting blood sugar is, for a bolus insulin, either what your next meal time is or 2 hours after the meal. If 2 hours after the meal you're less than 10, then you had enough insulin to cover it. If your fasting blood sugar is less than 7, your basal insulin is covering it. I hope that sort of helped.
Thanks. Yeah, that definitely does. The next question is, does glycon work exactly the same way as metformin?
Glycon is metformin. Glycon is just a brand name.
Perfect. The next one is Januvia and metformin is a common combination in therapy these days. Is it common to have
Sulfonylureas.
Okay, added to this drug regimen?
It's not unlikely because you're looking at the Januvia is that DPP-4 inhibitor. So it's keeping that little GLP-1 along longer. The metformin is slowing down that release of it from the liver. So if they don't think the Januvia is having enough of an action, they're going to add that sulfonylurea to squeeze your pancreas. Sulfonylureas, you must have some beta cells left. And I believe that in a lot of cases you see people that are on a sulfonylurea for a long time and their blood sugars keep going up. But yes, it can be used with Januvia and metformin.
Perfect, thank you. So again, if you guys have any other questions, please type it into the Q&A box in your bottom left-hand corner. And as you're listening to the Q&A session, and if you have 2 minutes, if you would fill out the post survey, we would really love to hear from you, and so we can better our programs. And so we have a couple more questions here. Is taking Lantus insulin twice a day a good way to control high blood sugars before supper? I have a person who takes Lantus at bedtime and in the morning. Timing isn't always the best, not always taken at the same time.
Well, depending on who you talk to, I've been at diabetes conferences that says there's absolutely no reason you shouldn't just take Lantus all at one time. And sometimes it's split if you're taking more than 50 units at a time, because that's a large amount of insulin. And sometimes rather than have 2 shots at one time, they'll split it for morning and bedtime. The challenges with your high blood sugars before supper really may be related to mealtime. And Lantus is a background insulin. In theory, if you didn't eat all day and you took Lantus or Levemir, your blood sugar would essentially stay the same because it's not covering meals. And some people are getting that high blood sugar before supper because it's what they ate, and their lunchtime, the medicine they take isn't covering the blood sugar raised from lunch. And so that's why they have blood sugar that's high before supper. If you didn't eat all day and your blood sugar in the morning and twice a day Lantus, then your fasting would be under 7 and your before supper would be under 7. But because you have meals in between, you have to kind of decide what's the challenge. It may in fact be the blood sugar from a meal that is causing his high pre-supper blood sugar.
Thanks for that explanation. It was very thorough. So we have another question here. Januvia indicated for GFR above 50, Tradjenta indicated for all renal patients. Do you recommend a change from Januvia to Tradjenta with renal patients?
Yes, that is actually the recommendation. For anyone with a decreased renal function, Tradjenta has only about 5% excreted through the kidneys. So it is a good choice for anyone with decreased renal function. Hello? We ended?
Oh, sorry about that. I was still on mute.
Okay.
Oops, okay. Sorry about that. Okay, so Januvia approved for use with insulin, but I have not heard regarding Tradjenta. Part 2 of question.
Part 2 of question. Well, you know, I'm not sure of the answer to that question. I will tell you, if Januvia is approved, the whole class is approved. And I have seen a few people that are just taking a bedtime insulin that are using a DPP-4 inhibitor, because of course that DPP-4 inhibitor is trying to help with the mealtime as well, because it's released in response to your blood sugar. If you were on a mealtime insulin as well, I'm not certain of the total benefit. I'm sorry, I'm not clear on that answer.
That's okay. Thanks for trying to answer it. Would taking Lantus and a short-acting insulin before breakfast help with supper highs?
It's a Surprisingly enough, the answer to that might be yes. Again, it kind of depends on what's causing that high blood sugar at supper. Because what they say is if you can get your fasting blood sugar under control, then the rest of the day will be better. And because a lot of times people suffer from something called a dawn phenomenon, where you get hormones released in your body that causes your blood sugar to rise naturally in the morning, it is one of the reasons why when they're doing that basal plus 1 dose of fast-acting, a mealtime, that they often will put that mealtime at the morning, because sometimes that makes the rest of the day fall into place. However, if the person's at that point where their blood sugar is always high at different times of day, then they're probably a candidate to have a second dose of a mealtime insulin.
Thanks for clarifying that. So the next question is, what is the cost of Canagliflozin, and do you think the government drug plans will pick them up?
I don't actually recall the cost of Canagliflozin. I don't actually dispense drugs. I'm just a counsel, so I cannot tell you the exact cost. Government does not cover new medications at the beginning. We'll hope that it does get coverage eventually. And I'm sorry, I can't remember what it is, but I believe someone told me it's around the same price as DPP-4 inhibitors, so probably about $70 to $80 a month.
Thanks. And just a comment here, this person wants to point out that Victoza is expensive and may not necessarily work for all persons to help with weight loss.
And that's why I pointed out that in the studies with Victoza and GLP-1 analogues, the actual weight loss was 1.9 kilograms on average. There are reports of large amounts of weight loss, but I have seen people who take Victoza and do not lose any weight at all.
Perfect, thanks. So we're coming to an end to the presentation, so I'm just going to go through the last couple of slides, but if you do think of another question that you'd like to ask Elaine, again, please type it into the Q&A pod and we'll get to it in a little bit. So just one more comment here. This person wants to thank you, Elaine, for an enlightening session. This person learned a lot and didn't expect to learn so much new information.
Oh, good. Thank you.
So I'm just going to continue with the slides here. So thanks very much to everyone who attended the webinar today, not tonight, and for all the wonderful volunteers who coordinated this session. We'd like to remind everyone that you will be sent an evaluation survey tomorrow and encourage you to complete it. It should really only take about 2 minutes and provides us with very valuable information. So this webinar is generously supported by Janssen and OneTouch. And if you haven't seen this already, it's the Diabetes Charter, and we'd like to encourage you to sign it. And if you'd like to sign it, or for more information, you can go to www.mydiabetescharter.ca. And so again, the development and delivery of impactful programs such as our Canadian Diabetes webinar series is made possible through the generous support of our donors. If you enjoyed the webinar and would like to make a donation, please visit us at our website at www.diabetes.ca, or you can call 1-800-BANTING. So thanks again, everybody, for coming out today and supporting the webinar. And again, if you'd like a copy of the slides or you have additional questions, you can email me at infobc@diabetes.ca.